following the two lectures by Dr. Khairul and Dr. Nabila, now it's my turn to demonstrate on the approaches of for the anterior abdominal wall block. Assalamualaikum and very good morning. I'm Dr. Amir from Hospital Kuala Lumpur, your demonstrator for the anterior abdominal wall block approach for today. Before I go further into the approaches for the anterior abdominal wall, it's very important to review or to understand the concept of the anterior abdominal wall as a whole. I'm going to introduce the concept of anterolateral abdomen and the anterolateral abdominal wall and the posterior abdominal wall. Okay. The borders of the abdominal wall are formed by the costal margin, the iliac crest, and the symphysis pubis. Okay? You have to understand the abdominal walls are formed by the muscles, aponeurosis, fascia, and not forgotten the neurovascular structures. Okay. First, I'm going to show the sonoanatomy of the abdominal wall. I'm using the high frequency linear probe. First, I'm going to show the midline. There's a presence of the rectus, a pair of rectus abdominis muscle. Okay. So, and if I move laterally, okay, below the rectus abdominis muscle is the transversus abdominis. Can you see the hypoechoic structure? And if I move the probe laterally, the three layers abdominal muscles, namely the external oblique, the internal oblique, which is usually the thickest layer of the muscle, and the transversus abdominis muscle. If you can follow the transversus abdominis muscle, if I move back my probe towards midline, note that the transversus abdominis muscles, okay, above the umbilicus also extends below the rectus abdominis muscle. Okay? So now I'm going to move my probe inferiorly and concentrate on the transversus abdominis muscle. Okay. I'm at the level of umbilicus. The relationship of the transversus abdominis muscle at the level of the umbilicus is now more lateral, and it lies in three layers. Okay. Namely, again, EO, the external oblique, internal oblique, and the transversus abdominis. Coming back midline and a bit lateral, I just want to show how the external oblique muscle, when it reaches the ASIS, or the anterior superior iliac spine, it becomes smaller and taper and become the external oblique aponeurosis. So below the ASIS level, there is no external oblique muscle, and only the internal oblique and the transversus abdominis muscle. Okay, now I'm going to demonstrate how the approach for the I think Dr. Nabila has explained the few approaches of the anterior abdominal wall block. In planning the appropriate or the correct block for the surgery on the abdomen, it's very important to know the innervation and how the thoracoabdominal nerves supply the anterior abdominal wall. I think Dr. Khairul has explained, has shown a nice picture how the nerves travel from the spine. The ventral rami give rise to the lateral cutaneous nerve, and it continues to the midline of the abdomen. But what I'm trying to stress here, especially the upper branches, namely the T6 to T9, the T6 will enters and supply the abdomen just lateral to the inner alba. It's very high and it comes out from the costal margin quite early, and followed by the 7, 8 and 9, and all these branches are medial to the, if you can draw a imaginary anterior axillary line. The branches are from T6 to T9, all are medial to the anterior axillary line. And the other branches for T10, 11 and 12 will run lateral to the anterior axillary line. Okay? So it's very important to understand that in planning your blocks on the cervical of the anterior abdomen. Okay, so first I will demonstrate to you the classical or the lateral approach of the TAP block. Okay, TAP block I think has been discussed. TAP block is actually the deposition of the local anesthetic in the TA plane, which is in between the internal oblique and the transversus abdominis. So first palpate for the iliac crest and the costal margin. Okay, so I prefer to run my probe from rectus abdominis, from the midline, so that I got a clear orientation, and I move my probe laterally. Now I got the 3 layers of the muscles, the EO, the IO and the transversus abdominis. I will slide my transducer till at least mid-axillary line, okay, and the needle approach of this block will be somewhere from anterior axillary line and targeting the layers in between internal oblique and the transversus abdominis. So I will inject about at least 15 to 20 ml of local anesthetic, and the lateral or classical TAP, it's good to cover the dermatomes of T10, T11 and T12, because once you inject the local anesthetic, the local anesthetic spread will be limited by the costal margin and the iliac crest, and it just covers the dermatomes T10, 11 and 12. Okay. Okay. The other variations of TAP block, namely the subcostal TAP, is to cover the upper dermatomes T6 to T9. When the traditionally, when it was first described, okay, the subcostal TAP block, you will need a long needle, 100 to 150 mm needle. Okay, it's parallel to the costal margin. The transducer position is parallel to the costal margin, and I will insert the needle and inject the local anesthetic in between the rectus abdominis and transversus abdominis, and I will move my probe along the costal margin and deliver my injection further lateral. Okay, but I think as people realize that actually you don't have to do that. Okay, injection at the subcostal TAP block, injection in between the rectus abdominis muscle and the TAP block. Sorry, if you can show. Yep, that layers will block the T6 up to T9. Okay, if you are not, if you think the spread is not adequate, probably can supplement somewhere a bit lateral rectus. Can you see the lateral border of the rectus abdominis and the layers below the rectus abdominis, the transversus abdominis muscle? Yes, you can inject the local anesthetic to. This is the oblique subcostal TAP. Okay, so it's up to you to decide whether you want to give what's your preference. Okay, the subcostal TAP or the oblique subcostal TAP. Okay. Next block that I'm going to demonstrate is the rectus sheath block. Traditionally, rectus sheath block is performed at the level of the umbilicus. It's actually a deposition of local anesthetic below the rectus abdominis muscle. In between the rectus, the posterior border of the rectus abdominis muscle and the posterior rectus sheath. Okay. I think Dr. Nabila has explained or highlight a bit the formation of the rectus sheath block above the umbilicus. The posterior rectus sheath block is actually formed by the transversus abdominis aponeurosis and the internal oblique aponeurosis. But below the umbilicus, there's no posterior rectus sheath block proper. It's actually if you can see below the muscle, there are two layers, but one is formed by the epimysium of the rectus abdominis muscle, and the second layer is formed by the transversalis fascia and the peritoneum. So it's quite risky to form, or to block below, to perform a rectus sheath block below the umbilicus. Okay. So how do you perform the rectus sheath block? My needle approach will come from lateral to medial, okay. And once I reach the posterior rectus sheath, I will inject and try to get the rectus abdominis muscle elevation. Okay. The volume of local anesthetic I will use is around 15 to 20 mils per side. Okay. I have to warn you, there is a presence of the epigastric vessels in this area, so you have to be careful not to cause hematoma or bleeding into the muscles or below the muscles. Okay. So we have now, I have now discussed the approaches to the anterior abdominal wall blocks to cover T6, 7, 8, 9 via the subcostal and oblique subcostal TAP block, and for coverage of T10, 11, 12, I will perform a the lateral or classical TAP block. If your incision lower down, that needs coverage of L1, you have to perform the ilioinguinal or iliohypogastric nerve block, which is the terminal branch of the L1. Okay. So, palpate for the ASIS. Okay. You remember the layers of the abdomen close to the ASIS. Okay. If you are slightly above the ASIS, you will still get the 3 layers: external oblique, the internal oblique, and the transversus abdominis. Okay. So the ilioinguinal iliohypogastric nerve block is in between the internal oblique and the transversus abdominis plane. So you either can give or deliver your local anesthetic here. I prefer to come from medial to lateral, okay, about 10 mils of local anesthetic. Or if you want to block lower down, just remember that the external oblique muscle has now tapered and become external oblique aponeurosis, and you only you block in between the internal oblique and the transversus abdominis. Can you show that? Yes, that's the plane. Okay. So if you can see the presence of neurovascular structure there, I think that is the branches of the deep circumflex artery, okay, the ascending branch. So be careful not to hit the deep circumflex artery. Okay. So you have a few choices to block the whole abdomen anteriorly. Okay. So let's say this is a hypothetical patient which just had undergone laparotomy with a midline wound, and can I get the smaller? And surgeon also inserted the drain. Okay, so this is what I usually do in my clinical practice. Okay, I prefer to block my patient post-operatively, but the problem, the presence of dressing on the abdomen will make my block difficult. Okay, so to cover the T6 to T9, I will do somehow the subcostal TAP, okay, and I will block, yes, that layers, okay, in between the rectus abdominis muscle and transversus abdominis. I mean the plane in between rectus abdominis muscle and transversus abdominis. Okay. I noticed that in this volunteer, the rectus abdominis muscle actually quite wide. Okay. The lateral border of the rectus abdominis muscle is actually almost reaching the anterior axillary line. Usually, the rectus abdominis muscle, okay, once you cover with the dressing, half of the rectus abdominis muscle already covered up by the dressings, and you can't see the other half of the rectus abdominis muscle. Okay. So I will do first injection, and then the subcostal block, okay, and then the intercostal, the lateral tap block, okay, and I will repeat the on the other side, the subcostal tap block, and for the other lower abdomen on the right side, because there's no presence of incision on the right iliac fossa, I prefer to perform rectus sheath block, but below the umbilicus. Okay. I totally agree with Dr. Nabila. You have to be careful that because there's a deficient layer of posterior rectus sheath below umbilicus, but with the ultrasound guided technique, and you must always visualize the needle tip, this technique is fairly safe. So I will perform a 4 injection in this patient and tailor my site of injection according to the incision. If there's incision lateral to the midline, I will supplement, I will opt for lateral tap on that side. If there's no incision lateral to the midline, so I will perform rectus sheath block on that side. Okay. So that's all for my demonstration.